Welcome, everyone. This is Ann Cuppinger from the Community Technical Assistance Center, and I want to welcome you to today's webinar, Preparing for Managed Care for Youth Peer Support and Training Providers. So just a couple of technical details before we get started. There will be time for questions and answers at the end of today's webinar, so we encourage you to think of your questions throughout the webinar and send them to us via the chat. Everyone's muted because there are quite a few participants in the webinar, but we really do want to hear your questions. So if you would like to chat them to us, you can open up the chat box by clicking on the speech bubble on the bottom of your screen, and you can chat your questions to the host, and we'll be gathering those up to answer at the end of the webinar. The slides and the recording for today's webinar will be posted on the website in about a week or so. And you can find those by going to the upcoming events tab on the webinar and navigating to today's date on the calendar. And when those slides are posted, you'll find the slides and the recording there. So also a quick reminder that the information that we're presenting today is current as of today, and that this presentation is not the official document that should govern your understanding of the finer details of how these services are to be provided. For that, we'll ask you to consult the provider manual, and we've provided a link for that further on in the presentation today. So our agenda for today is to provide you with an overview of youth, peer support, and training, and the components of that service, some of the benefits of that service, and why you might think about referring a youth to youth peer support or providing that service, the process for credentialing or certifying the youth peer advocates or SERPA youth who will be providing that service. We'll provide you with a few examples of the way in which the service might be used, talk about some of the pathways into care, so how is a child referred or a youth referred to the service. Then we'll talk a little bit about some of the basics of billing Medicaid managed care and contracting, and look a little bit at utilization management and medical necessity in the context of managed care. And then, as discussed, we'll take your questions. So this is the timeline of all of the transitions that have been happening over the past year. And I just want to point out the highlighted section below, youth peer support and training, as well as crisis intervention, the last of the two child and family treatment and support services, will be coming online in January in both managed care and as fee-for-service. There will be some additional changes happening after that as it relates to children in foster care being brought into managed care. But with the inclusion of youth peer and crisis intervention, we'll have all 6 of our CFTSS services online. So just a quick reminder, some of you are currently providing or receiving youth peer support and training because you were providing that under the old waivers. And when those waivers merged, we wanted to ensure that there was continuity of care. So you were authorized to continue providing HCBS, providing youth peer support as an HCBS service between April 1st and this upcoming January, when it will become a CFTSS service. So during that period of time, the youth peer support and training is only available to children who were enrolled in the waiver. So there are some youth peer support services being provided through other funds, but that's separate from this. And as of January 1st, youth peer support and training will be implemented as a CFTSS service and available to all children with Medicaid who meet medical necessity criteria. And the rest of this presentation relates to youth peer support as a CFTSS service and what things are going to look like as of January 2020. So this is the reference to the manual that I talked about at the beginning. This is where you can find all the rules and regulations that are specific to this service and the other CFTSS services. And with that, I'm going to turn it over to our colleague at OMH, Meredith Ray Labatt. Thank you.
Hi, thank you, Anne, so much. I appreciate it. Again, this is Meredith Ray Labatt. I'm with the New York State Office of Mental Health, and I'll be going over the Youth Peer Support Service on behalf of our state partners here at New York State. So we're going to be talking a little bit about what this service entails, what it looks like, and what it does for young people in New York State, and how excited we are to make this more broadly available to young people through the state plan service. Great. So we're going to be talking about a couple of different components within youth peer support and the type of activities that a youth peer would engage a young person in to help them address issues related to their mental health needs and substance use needs. Okay, great. So one of the things that a youth peer does is to work with a young person on developing skills related to managing their symptoms, navigating services, and building wellness. One of the great resources and benefits of a youth peer is that they themselves are someone who has lived experience in the children's mental health system, and that they themselves at one point in time were also navigating the mental health system or a substance use system, and really learning how to be an advocate for themselves and to deal with the challenges that they were facing when they were a young person. And so with the skills that they were able to develop as a young person and learn through their own experience, part of the role of a youth peer is to guide and support a young person in their own journey through the mental health and substance use systems, and in learning how to become an active, engaged young person in their own treatment and their own service provision, and how they could do that to their benefit and to increase their wellness, resiliency, and recovery. And so they work with them on developing those skills, also coaching them on how to really promote wellness and to integrate wellness into their daily lives. Wellness activities are very important for a person's recovery and their mental health needs, and so really supporting the young person in understanding the value of positive and effective life decisions in your health and wellness are important, and how to model that, and really how to support their hope and their recovery and their resilience about their future and about how they could benefit from these new skills. Obviously, a big part of a youth peer's work is to engage a young person and helping them to understand the benefits that the system can provide to them if they were to engage in services, and then also what they might be able to expect when they're transitioning from maybe the children's system into the adult system, and some of the changes in the different types of services that are available to them, or the different levels of care that the services provide. And so really helping to encourage the young person's active involvement in their treatment planning and the receipt of their services, so that they can really drive the goals and the types of services that they engage in that really are well suited for them and that meet their needs where they are, and that they're choosing to really participate in, and that they're really being the driver in the services that best suit their needs. Obviously, a big part of becoming a driver of your own treatment and your treatment plan is to really advocate for yourself and to learn how to be empowered to really speak to what will benefit you and what your needs are and what your desires are and what you're planning to get out of the services you're receiving. So really how to connect young people to other community peer support groups, to speak to other young people who are also engaging in the mental health system or substance use system and experiencing maybe some of the challenges that they're experiencing, helping them to understand how to communicate their perspective and how to really advocate for what it is that they want and what they need, and also how to model those things and to serve as a mentor about how to really best communicate your desires in a way that is productive and in a way that people can listen and to help you best. Also, most important is to how to connect to community resources and natural supports. A young person navigating a system all by themselves can be very challenging, and so really identifying how to identify who can support that young person, helping them to get what they need, and how to also engage them in activities that are pro-social and productive, so that they can develop a support network with other peers who have similar experiences or who are of the same age and of same interests. So as I said, what does youth peer support and training offer youth? Because of their lived experience, youth peers offer a very unique resource and a unique perspective. As someone who has firsthand understanding of navigating the various child-serving systems, they themselves can really communicate the benefit of the services to the young person and the child, and to really encourage them to engage in services in ways that will best meet their needs. It's also obviously very beneficial that they're usually in closer proximity to the young person's age, and so they can really understand directly where the young person is coming from, because it wasn't that long ago since they were that age as well. They serve as an advocate for youth-guided practice, really modeling how a young person can take control and guide their services and to make informed decisions about the type of activities and services they want to be engaged in. And they, of course, support engagement and continuity across all supports and services. So they're really working to assure that a child really remains engaged in services for continuity of care purposes, so that they can maintain the gains that they might have received and achieved within services for the long haul. They can help facilitate smooth transitions to adult services if the young person is aging out of the children's service system and needing continued services in the adult system. And of course, they support youth in learning skills in different settings across all life domains. So the youth peer can help them in negotiating their needs and their services within a school, within the community, and within other child-serving or adult-serving systems. So what makes a young person a youth peer advocate, or what's also known as a certified recovery peer advocate with a youth parenthetic? So these are the people who would be providing the youth peer services. They need to be certified or credentialed in this profession in order to provide the services and in order to enable those services to be billed through Medicaid. Generally speaking, a youth peer advocate is a credential and is an individual who has had life experience in the children's mental health system of care, whereas a certified peer recovery advocate with a youth parenthetic is an individual who has had experience in the substance use system and are in their own recovery. And so these individuals can complete the credential and certification in order to become a Medicaid reimbursable service. So for youth peers, they can get their provisional and professional credentials through Families Together of New York State. And SERPA-wise, as we call them, can obtain their certification as administered by Alcoholism and Substance Abuse Providers of New York State, which is called ASAP. So in regards to a youth peer advocate, again, this is a young person who generally is going to be working with young people who have a myriad of needs, but generally one of the primary challenges that they're likely encountering is one of some mental health needs, because you would need a diagnosis. So the individual would be between the ages of 18 and 30 years old. Again, they're within close proximity to a young person, and have self-identified as having firsthand experience within generally the children's mental health system of care, so having a myriad of potential challenges during their growing up. They are able to use that lived experience to really support other young people in their own development of resiliency and recovery. At a minimum, they have a high school diploma or a high school equivalency. And they must obviously complete the credential, which is a level 1 and level 2 training of the Youth Peer Support Services Advisory Council recommended state-approved training for YPAs. And so we'll talk a little bit more about that next. So what does this credential really entail? So really, in order to be a youth peer advocate, in order to get the professional credential, you must submit 3 letters of reference attesting to your suitability and your capacity to conduct the role of a youth peer advocate. And one of those letters of reference have to be from a supervisor. You obviously need to agree to practice according to the Youth Peer Advocate Code of Ethics. You must document 600 hours of experience providing youth peer support services. Now, again, this is a professional credential. I will say that you are able to, initially, youth peer advocates start off with what's called a provisional credential, which means that they take the level 1 training and they begin to provide the services, and they can be reimbursed for Medicaid under the provisional credential. And what they do is they work towards the professional credential. So after you've completed the initial level 1 training and you've started to provide the services, you continue to document additional hours of experience. You take the level 2 training, and then you're able to work towards your professional credential. Once you have the credential, you also need to complete 20 hours of continuing education every 20 years, and your credential will be renewed. Obviously, we would expect that you would demonstrate qualities of leadership, including what it means to have knowledge of advocacy and can facilitate peer-to-peer groups or activities. And then, of course, be supervised by a credentialed YPA or someone who is considered to be a qualified mental health staff person, which we'll talk more about later as well. Well, as I just said, the good news is that a youth peer advocate can begin to work as a youth peer prior to completing all of those professional credential level criteria. So prior to completing a full professional credential, you can get what's called a provisional credential, which enables you to begin providing Medicaid reimbursable youth peer support services right after you have completed the initial credential components, which again, obviously you need lived experience. You have completed level 1 of the YPA online training. You have 2 of your 3 letters of reference, and then you have 18 months with which to complete all of the other components, your 600 hours, your additional letter of recommendation from your supervisor, and all of the other components within 18 months, so that you will then at that point, after the 18 months, if you've completed all the other aspects, you will be considered to have a professional credential, and you'll be fully credentialed, and then you would just need to sustain that credential with continuing education credits every 2 years. Okay. Now, as far as a SERPA-Y certification goes, to be eligible to be a certified recovery peer advocate youth, again, you also must be between the ages of 18 and 30 years of age. Your lived experience must include having been impacted or affected by substance use disorders and or be in recovery from substance use disorders. You need to have a high school diploma or equivalency. You need to complete a minimum of 46 hours of content-specific training covering a variety of topics with a demonstrated minimum of those hours specifically related to youth peer support. You also have to have a documented 1,000 hours of relative work experience, and documenting less than 1,000 is feasible, but you have to have at least 500 of related work experience that can be acceptable if you have a bachelor's degree. So it's 1,000 with a high school diploma, or you can have 500 hours with a bachelor's degree. And you've been certified by OASIS as a KSAC or a KSAC trainee or prevention professional and completed a 30-hour recovery coach academy training. So 1,000 with just a high school diploma, but if you have a bachelor's, a KSAC or a KSAC trainee or a prevention professional or completed a 30-hour recovery coach academy training, you can have 500 hours. Seemed backwards before, so. So again, in addition to be eligible to be a certified peer advocate family, an individual must also have evidence of at least 25 hours of supervision specific to the performance of the domains of advocacy, mentoring, and education, and such. And supervision must be provided by an organization documented and qualified to provide supervision. This is a supervisor qualification, isn't it? Yes, okay. This is for, to be a SERPA family advocate, I think. Pass the New York, oh my gosh, they didn't give me acronyms. I don't know the acronyms. Pass the NYCB, IC, and RC peer advocate exam or other exam by OASIS designated certifying body, submitted 2 letters of recommendation, and completed 20 hours of continuing education every 2 years, including 6 hours of ethics. That's right.
And the details of this will be in the manual.
All of this is in the manual, and I apologize, I don't know the descriptions of the acronyms, as I'm sure everybody deals with on a regular basis whenever the state provides a presentation. So why veer from formula? Great. Okay. Now, in order to supervise a youth peer advocate or a SERPA-Y, the individual has, a number of individuals have an opportunity to be a supervisor. Obviously, New York State would love to be able to get to the point at which we build a system of care in which peers are supporting and supervising peers. In order to do this, we need to build a system of having a multitude of available peers that could then become supervisors themselves. But in acknowledgement of us not yet having built that system of care yet, and this is being a new area of service, wherein we're just now creating a workforce, which we're very excited about, we acknowledge that there might not be a capacity for there to be those individuals who qualify as supervisors yet. But we're hoping that, again, over time, we have a number of maybe youth peers or family peers that have been peers for many, many years, 4 to be exact, and have the credential and qualify as being supervisors, because they will understand the role and the field and really be value add to the supervision of a new peer coming into the work and into the field. But so a credentialed youth peer or family peer, for that matter, who has 4 years of experience, one of which has to have been, at least one of which has to have been with a credential, professional credential, can be a supervisor of a youth peer or a youth peer. Or, again, because we don't have a large enough workforce yet, a qualified mental health staff person. And there's a huge list of who these are. It's a very long list of qualified mental health staff people who are found in regulation in 594 and 595. And so those, again, are available in the manual, and they're in appendices in the back. Mm-hmm. So there's a large breadth of individuals who would fit that bill. Next. Okay. And here's just a general, just to give you a sense, it's a large breadth of individuals. It could be a master's or bachelor's degree in human services fields, an associate's degree with 3 years experience, a high school degree with 5 years experience, and so on and so forth. So just to give you a sense of the breadth and scope, there's a myriad of people that fall under these categories and would qualify as being supervisors of youth peers. Okay. Supervisors, we've also provided some additional supervision guidance in the manual just to kind of express that we feel it's very important for youth peers to be adequately supported in their role, and that they should get you know, generally speaking, weekly supervision, let's just say. Obviously, you know, we've said been delivered for every 40 hours of actual duties performed. I think that the intent here is to communicate that young people, particularly new to the work, particularly new to a field and a profession in which credential is new, and this is something that is a really important role, but one that really needs some guidance and support. And so really just communicating the importance of regular ongoing support to direct the young person on the importance of their role and what that should look like, and to clearly integrate them into the agency as someone that you have regular contact with. So, and those are just some other ways in which, you know, agencies can be flexible around the provision of supervision. Again, their guidance. Okay, so in order to be a provider of youth peer support and have employed youth peer advocates working in your agency, you must be designated. Oh, and to bill Medicaid, that's the most important part, under CFTSS. You must be designated by New York State, and so you would have to have submitted a children's provider designation application to the designation portal, and you would have been reviewed by the state partner team, and we would have issued you a designation letter that says that you are designated. And so what we would be looking for is that you have experience as a child serving agency, and that you have done some comparable level of work working with young people with, again, mental health or substance use challenges in New York State.
Alrighty, hi everyone, good afternoon. My name is Shannon Fortran. I work with Meredith Ray-Labatt at the Office of Mental Health. I'm going to walk us through 2 case examples to kind of highlight some of the components that Meredith went through regarding the, we call them actually service categories that comprise youth peer. So our first example is Leah. So Leah, age 17, has substance use challenges. She receives youth peer services from a SERPA-Y named Brielle. Brielle reassures Leah, and by sharing her own personal recovery resilience story, as appropriate and beneficial, helps restore Leah's hope and recovery. Brielle has a goal of getting back, so it looks like Leah would have that goal. So Leah has a goal of getting back involved with friends after a long period of time in which she just stayed home. Brielle connected Leah to a local community center to participate in substance-free hobbies and develop her skills for maintaining wellness. Brielle also helps Leah explore and understand the available adult services that she will soon be eligible for in order to prepare for a smoother transition. So if we break this down a little bit, so if you think back to some of the components that Meredith went through, empowerment certainly, sharing a personal recovery resilience story can certainly be a significant part of service delivery with youth peer. It's not necessarily inherent. It's certainly for the benefit and the promotion of the skills related to the recipient themselves. And obviously connecting to, if you think back to what Meredith said, community connections and natural supports. So just to reiterate, so CFTSS is actually available until the youth turns 21. However, it's incredibly critical for somebody that's nearing the age of 18. There might be circumstances in which there are adult services and supports that may better meet their needs, that they may elect to participate in. So it's really critical that a youth peer in their role be familiar not just with the child and adolescent serving systems, but also in the adults so that they can appropriately link and inform their clients. Okay, and our second example is Damien. So Damien, age 15, was not engaging in services, said he was, quote, sick of a bunch of adults telling him what to do. His challenging behaviors at home and school were putting him at risk for going back into placement. He agreed to talk to a youth peer advocate because his care manager explained that a youth peer could help him have a voice in what his services look like. Alex, who I assume is the youth peer, got to know Damien, who shared with him that he understood how hard it was to feel no sense of control. Alex helped Damien talk to his parents and providers about what he was feeling and they were able to make some changes. Damien confided in Alex that he was so far behind in school that he was just zoning out in his classes. With everyone's okay, Alex helped Damien visit 2 alternative school programs that might meet his needs better. So I think a very strong component, not just in this service, but in family peer as well, is when the peer can really function as a bridge of communication between the youth themselves and other service and treatment providers, and really helping to empower them to advocate for themselves and their own treatment and service provision, and really giving them a voice, because how often is it that service providers will, work with the family to develop a treatment plan around the child, and that youth peers really intended to engage that child and youth in, cultivating their own voice and engaging them in that process.
Thanks, Shannon. Pathways to care, my favorite topic. So how do we get this youth peer support services? They sound awesome.
Don't they?
So as with any CFTSS, Children and Family Treatment Support Services, there are a myriad of ways in which a child can access the services. What's important, though, to remember about youth peer support and training is that, which is on next. We'll talk about the medical necessity, but they have to meet the medical necessity of the service. They have to have a diagnosis. They have to qualify for the service, which is actually on an upcoming slide. So we'll talk about that soon. But generally speaking, anybody who meets that criteria, anybody who would benefit from the service can access the service. So Oh, there we go. To access it, a child must have a documented diagnosis. If the child is not yet diagnosed, a referral must be made to a licensed practitioner who has the ability to diagnose within their scope of practice. So that means that if someone is working with a child or a family member has a young person who they really feel would benefit from youth peer support, but the child is not yet diagnosed, then a referral would likely be made first to either the pediatrician or to a clinic or to an OLP who might be able to discern whether or not the child meets medical necessity for the service. However, if the child does have a documented diagnosis, maybe is already engaged in other services, a referral can be made by anyone for that child to youth peer support services if they have a documented diagnosis, mental health or substance use diagnosis. However, if for some reason the child is actively engaged already in treatment and they're being seen by a licensed practitioner of the healing arts, they can actually document the medical necessity for the service and kind of skip a step so that if they're referring directly to an agency that has youth peer support services, they can just start providing those services directly because they have a documentation of the medical necessity by the licensed practitioner. So that would be called a recommendation. That's like when a pediatrician gives you a script for physical therapy. So that would mean that the physician has already determined that you need physical therapy and that you've met medical necessity for it, so that you can bring that script right to the PT and they will be able to start providing services. So that's the difference between a referral. A referral means that the agency that you're making the referral to for youth peer services would then have to figure out how to make arrangements to get somebody to make a medical necessity determination to authorize the services, whereas a recommendation directly allows them to just start providing it right away. So again, the referral is when an individual or service partner just makes the referral. Everybody, I think, has a general sense of what a referral is. This person needs the service. It's contingent upon the agency receiving the referral to help figure out if the child meets medical necessity. Or working with other treatment providers to determine medical necessity and get that documentation. Or the other option is the licensed practitioner that the child's engaged with actively can make a direct recommendation, that's a written documentation verifying medical necessity, to the agency who's providing youth peer support services, and they can provide those services right away. Who are these licensed practitioners of the healing arts? What a strange term. Seems quite broad. Well, yes, it is. Here's why. Look how many people are underneath the category. We have nurses and psychiatrists, psychologists, social workers, therapists, physicians, and psychoanalysts or physician assistants. So a lot of folks who the child might be working with and engaged with in treatment or services can, if they identify the child as needing and would benefit from the service, can make a recommendation. But anyone can make a referral, nonetheless. So how would we make this recommendation? If my therapist and I've spoken to my therapist, I said, hey, I've heard about this youth peer support, and the therapist says, yeah, I think Johnny would really benefit from having a young person help him really understand how to actively engage in treatment and to figure out how to prepare for, becoming an adult and what the adult system might look like. I think that would be a great idea. And the mom says, or dad says, well, can you make a recommendation for the service? And he says, sure, how do I do that? And they say, well, here's a form. On our website, here, at this link, is an example of what a form may look like. Obviously, folks don't need to use it. Practitioners don't need to use this particular form, but it does give them a sense of what's required and what would be useful when making a recommendation to a youth peer support and training provider. So who can meet criteria for qualifying to receive youth peer support and training services? So obviously, number one is that the youth has a behavioral health diagnosis. And that means that they have a documented mental health or substance use diagnosis. Or, number two, you'll note that it also says that the youth displays a demonstrated evidence, skill, or loss undeveloped as a result of the impact of their physical health diagnosis. New York State is exploring the applicability of peer services for young people who have physical health diagnoses. This field is being developed, and the guidance is being developed for this particular component. However, as always, and as always it has been, if it happens to be that a young person with a physical health diagnosis has a concurrent mental health or substance use diagnosis, they of course would qualify under Criterion 1, and they would be able to receive this youth peer support service. And then finally, the youth requires involvement of youth peer advocate to implement an intervention outlined in the treatment plan. And the youth demonstrates a need for, and these are just basically outlining the components that we talked about earlier. So basically, it's saying that the young person would benefit from the receipt of an activity or an intervention that is reflective of the components of the service that we talked about early on. Obviously, the youth is involved in the admission process and helps to develop the service goals because it must be youth-driven and person-centered, and the youth is available and receptive to the service because, as with any treatment service, it's voluntary, and the services are recommended by a licensed practitioner of the healing arts. Again, that means through recommendation from an external practitioner or made by the determination made by the agency who's providing the youth peer support services. They've engaged someone to make a determination of medical necessity within the organization. Okay. So one of the things that's necessary in order to provide youth peer support and training services is the treatment plan. As with any behavioral health service, you have a treatment plan that guides the work that's being provided and conducted. And so each service has to have a treatment plan under CFTSS, although it can be a collective treatment plan with multiple CFTSS under one if possible in your EHR. But the treatment plan includes the goals of what you're trying to achieve by the provision of the services, the way in which you're going to provide the services, so the interventions and the activities that are going to be, or the components that are going to be provided to address that goal. And then, of course, usually it also includes the frequency, scope, and duration of the activities and the interventions that are going to be conducted. Treatment planning is an active process that engages the young person and their family and caregiver. There is no required treatment plan format or form. We require treatment plans, as with any service, to have the core components of most treatment plans, so they're pretty typical of any EHR. The supervisor the client and the provider must sign off on the treatment plan to verify agreement and collective working towards what's been outlined in the treatment plan and guided by the young person. And again, the treatment plan is not the same as a plan of care. Just to be clear, a treatment plan guides treatment provided by a treatment provider, a practitioner or a provider under CFTSS. A plan of care is a document that guides what care is being provided and what the needs are of the young person. So it's how to guide coordination, how to provide assurance that all services are being provided and received by the young person, physical, mental, all other types of wellness services are reflected on the plan of care. Treatment plan is very specific to the service that's being provided by the practitioner within their scope or within their service description.
Another case example. Okay, Loris is 14 and has had several hospitalizations over the past year. Things are going well at home, but her mother is concerned that Loris doesn't have friends and has said that she is embarrassed because of her hospitalizations. Loris's mother contacted the local youth peer support and training program and made a referral. So just to highlight, as Meredith said, so families and the youth themselves could actually make a referral. They wouldn't have to necessarily go through an outside provider. They could make a direct referral to the youth peer agency itself. The Youth Peer Support and Training Program helped Loris get a recommendation from her psychiatrist. Michaela, the youth peer, got to know Loris and helped her understand that she is not alone when it comes to feelings of stigma. Michaela also helped Loris get involved in a youth peer group and taught Loris some self-calming skills that she can use when things get rough in school. Michaela tapped into Loris's interest in the environment and helped her research volunteer opportunities in her community. So I think one of the great things about CFTS in general, not just youth peer, is their ability to really augment and support other services and treatment that the youth might be involved in. So in this case, if she's involved with a psychiatrist, some of the skills, if she's working on coping mechanisms, if she's receiving treatment, not just med management from that psychiatrist, youth peer can really help to augment and support those skills and reinforce them in the home and community as working with the youth themselves.
Okay, well, we're going to turn it back over to our colleague Yvette from MCTAC for the remaining slides.
Thank you, Meredith and Shannon, for reviewing the service components and detailing some examples of how this service may be beneficial to youth. As Meredith mentioned, this is Yvette Kelly with the Managed Care Technical Assistance Center, and I'm going to spend the next few slides just walking through some of the billing components for these new services. So just a reminder about some billing fundamentals. If a child is in a Medicaid managed care plan, then the provider will bill the plan for these services. Please note that plans are required to pay the government rates for at least 24 months from the date the service has been included in the benefit package, or however long New York State mandates. If a child is not in a plan, providers must bill fee-for-service for that particular child. And that single case agreements may be executed by plans for an identified member. So again, just some billing fundamentals to remember when billing for the service. Again, in order to bill the plan, providers need to be in network. And in order to be in network, you need to be a designated provider of the youth peer support treatment services, be enrolled as a Medicaid provider. I believe Meredith had mentioned that earlier. Be credentialed and contracted with the plan. For additional plan information, please visit our MCO plan matrix, which can be found on our website. There's also a link provided here, so when you have access to the slides, you'll be able to click there and get that information. Also, while today's presentation will provide an overview of the billing components associated with the delivery and claiming of these services, please refer to the billing manual as official guidance. So we'll review some components related to billing, but again, just want to caution everyone to make sure that they are looking through the manuals for all of the specifics around billing for these services. So youth peer support is divided into two different types of sessions for which you're able to bill, both individual and group. So claims for youth peer support are defined using distinct rate codes based on the type of service provided, again, either individual or group. It's youth peer support individual is billed daily in 15-minute units with a soft limit of 8 units per day. And youth peer support group also billed daily in 15-minute units with a soft limit of 6 units per day. And so when you're billing youth peer support group, please know that the group size may not exceed more than 8 members. So you'll have to keep that in mind. And also that this service here can be provided both on-site or off-site, as with the rest of the CFTSS services. When youth peer support is provided off-site, this service is billed using 2 claims, the first using the service rate code and the second using the off-site add-on rate code. When group sessions are provided off-site, each member of the group bills using 2 claims, again, the first using the service rate code and the second using the off-site group add-on rate code. Off-site is billed in daily 15-minute units with the limits equal to the max units per day for that service. There's also modifiers that are required, and so you'll have to make sure that you include this on your claim as well, although the order of the modifiers does not matter. So you just need to make sure that they're inclusive. Again, please refer to the billing manual for all applicable modifiers. Lastly, revenue codes must be included in a claim. Again, as with other CFTSS services, you're going to be using the following codes that you see listed here. In terms of rates for youth peer support and treatment services, they are currently not out but will be released soon. The current rates, again, I believe, as Ann mentioned earlier, these are interim rates for the provision of youth peer support and treatment as an HCBS services. These rates actually expire at the end of the year. However, when these rates become available, they will be posted to the DOH website. You'll also likely get an email indicating that the information has been posted if you're on a number of listservs, and we've included some information about that at the end of our slide deck so that if you're not signed up, you can sign up. Make sure you don't miss that information. And as well as when you have access to the slides, you'll be able, the information will be included on our Children's Transformation page, and the link is provided here. It is important to note that there will be an upstate and downstate rate as it relates to youth peer support services. And so just to give you a quick reminder of who's considered upstate versus who's considered downstate, here's a quick depiction and graphic of those. So you'll have that information. And again, when the rates are released, they will be accessible on our website. We'll try to keep people up to date regarding that. When submitting claims, both the provider and plan must adhere to the billing rules as noted in the billing and coding manual. Plans will support both paper and electronic submission of claims, and the plan will also offer providers an electronic payment option, including a web-based claiming system. Please refer to the individual plan provider manuals for more specific information related to their claim submission. While I know that some of you are providing other CFTSS services for which you're billing, we do recommend that you claims test for this specific service. We've been hearing from some providers that they're experiencing some challenges when billing for these new services, so it'd be helpful to identify any issues prior to the service going live. So again, just a reminder here that if you haven't done so, that we're going to recommend that you claims test for this new service, just to ensure that you're able to get paid for the services that you're delivering. As a reminder, plans are held to specific network requirements, and the state monitors these network adequacy regularly. So while it is within the plan's discretion to deny a claim for an out-of-network provider, some exceptions do exist. And for newly carved-in services, if a provider is delivering a service to the enrollee prior to the implementation date, so in this case it'd be prior to January 1st, 2020, the plan must allow the provider to continue to treat the enrollee on an out-of-network basis for up to 24 months following implementation. And the way that you would do that is you would execute a single case agreement. As the state has undergone a number of transitions, there have also been a few lessons learned along the way when it comes to contracting with plans. So providers are encouraged to review current and proposed amendments to provider agreements for consistency with the proposed Medicaid managed care model contract. If you have not done so already, you're strongly encouraged to finalize contracting with plans to ensure inclusion in their network prior to the effective date of this benefit expansion. If you, as the provider, are experiencing some roadblocks in contracting with plans, please do not wait to contact the state for assistance. The faster you communicate with them regarding the issue, the faster the issue is likely to be resolved. Again, there will be some resources and some mailboxes at the end of this presentation that you can reference if you are needing some assistance. All right, so next I'm just going to talk briefly about utilization management and medical necessity. I know that Meredith touched upon this briefly, and I'm just going to kind of walk you through some kind of what it means in terms of for this new service. So as a reminder, utilization management is the mechanism used to monitor and evaluate the overall appropriateness of service provision, which can include, but is not limited to, services to things such as service authorization, concurrent review, retrospective review, care management, and discharge planning. So designated providers must have the ability to bill fee-for-service and managed care, but today's presentation really is focused on the managed care utilization and authorization process. So UM will occur at different points in the service provision cycle. While there is no prior authorization required for youth peer support services, providers should notify the plan before providing services to ensure proper payment. It also helps the provider with understanding whether or not the family is currently receiving services from a different entity or another provider. So that is helpful. So again, while prior authorization is not required, it is highly recommended. Plans may also engage in concurrent review. And this is a process that ensures that treatment remains medically necessary and appropriate. And so when doing so, when plans request concurrent review before the 4th visit, the provider will submit a concurrent authorization request to the plan for that review. The provider has up to 3 visits before authorization can be required. The plan reviews the authorization request with supporting documentation to evaluate medical necessity. There is a template that providers can use. The link is provided here. However, this form is not required. Again, it's just an example. You're free to use it, but not required. A treatment plan will also be required, but not for the purposes of obtaining authorization from the plan, but more to assess the appropriateness of the services. It's important to note that plans may not conduct utilization management and service authorization for 180 days from the carve-in date of youth peer support. So again, January 2020, have 180 days before utilization management and authorization for the service is able to be done. I'm not going to spend a lot of time here because it's medical necessity has been mentioned several times throughout the presentation. But again, I just want to remind you that in order to be eligible for youth peer support services, a child must have a documented diagnosis. And so medical necessity is really the term used to determine if the service is reasonable and appropriate, and just to keep that in mind when you're doing service provision. In order to continue to be eligible for the services, all of the following criteria identified here must be met. So the youth must continue to meet the admission criteria, be actively working toward goal attainment, remain appropriate for the services to be provided in the home and community, be at risk of losing skills gained if the service does not continue, and be involved in treatment planning. In order to determine when the youth is ready for discharge, any of these criteria must be met, 1 through 6. And so again, they clearly don't meet the admission criteria, or for positive reasons, they've kind of met their goals. They're no longer in need of services. And on the other side, perhaps they want to withdraw their consent to participate. Or other things happen, they move out of town, but they're no longer interested. And so again, any one of these 6 criteria must be met. Again, I'm just going to refer you to the manual for further information. I'm not going to read every discharge criteria or medical necessity for discharge on the slide, but again, you can refer to it in the manual. And so that concludes the presentation part of our webinar today. As a reminder, we will have time for question and answers. So if you have not done so, please submit any questions that you may have. As we prepare for the question and answer phase of today's presentation, I do want to pass it over to Caitlin to talk briefly about user profiles. And again, there are a number of resource documents at the end of today's presentation that you can reference once slides are posted to our website. And so with that, Caitlin, I'm going to pass it over to you.
Thank you, Yvette. So we just wanted to take a minute to go through a quick housekeeping thing. As of today, we are going to be requesting that all users update their profiles on our registration system. So that means that the next time that you log in to register for a CTAC or a MCTAC event, you're going to see this screen asking you to update your profile. When you click proceed, then you'll be brought to the second screen where you'll be able to see your profile information, and we just ask that you just take a few seconds to look at your agency, position, and program and make sure that information is correct. If it is, hit I confirm. If it's not, please update it. And this just helps us know who we're reaching. It helps us ensure that people are on the listservs they need to be on. So please just take this quick routine update, and then you'll be on your way and you can proceed to register as normal. And with that, we're going to turn it over and open it up for questions. So please submit your questions into the chat. Thank you.
Hi, everyone. So we did get a few questions in. The first being, when will SERPA-Y be going live? And right now we don't have any representatives from OASIS with us, so we'd have to defer to them and get back to you on that.
Yeah, we'll ask.
We'll ask and let you know. TBD. Okay, the next question is, the age limit for direct service providers for youth peer support and training is 30. Is there an age limit for supervisors who are qualified based on their service experience as a youth peer? So no, as Meredith outlined, there are supervisor qualifications, but the age limit, that 30-year age limit, applies to those providing the service directly, not to the supervisor. So I think with that in mind, that if a youth peer were to want to be promoted to a supervisor over time, it's with that in mind. So no, that age limit does not apply to the supervisor as well. All right. If a young person at 19 decides to use adult services and then they decide it isn't a good fit, can they go back to the children's serving system until 21? So as we said before, the CFTSS is available to use birth to 21. So if they're still eligible and they're under the age of 21, they can certainly still receive services through that system. Okay. Can a youth peer advocate and a family peer advocate both work with the family at the same time, i.e. the youth peer advocate with the youth and the family peer with the parent and bill Medicaid? So yes, so as Meredith kind of outlined with the service components, so youth peer is a service directly with the youth themselves, and family peer, I know we didn't discuss that today, but family peer is a service with the family peer advocate and the parent or caregiver. So yes, those two services could occur concurrently to one another and bill at the same time.
Working off separate individualized treatment goals specific to youth peer for the youth and family peer for the family, guided on a treatment plan, yes.
Yes, thank you. All right, how does a collective treatment plan work? Does each service still meet its own goals and objectives, or could more than one provider be working on the same goal in different ways? So great question. We actually just hosted a webinar related specifically to CFTSS documentation, which would now include, after January 1st, youth peer. I would strongly encourage, if you haven't already, to listen to that webinar and also to review the CFTSS documentation guidance. That will be addressed in that, but just very, very briefly to answer your question today. They can work on an integrated treatment plan. The youth peer, if working on an integrated treatment plan, could certainly have a shared goal, as you're outlining. It could be quite clinically appropriate that they have a shared goal, but they would need to identify that goal as it relates to youth peer and have their own specific objectives and methods or interventions. And that kind of speaks to when Meredith mentioned scope, duration, and frequency on the treatment plan. But again, we go into this in a lot greater detail in a webinar that we just hosted, actually on Halloween. So I welcome you to visit CTAC's website and review that.
Two more, yeah.
Okay, we got some more. Bear with us for a second. Can you clarify off-site? If services are provided at a site that is not designated, is it considered off-site? Or is it only off-site if the provider of services travels to the client's location? So right, so off-site does involve travel because that's what it's covering. That additional reimbursement is covering the travel. So say, for instance, that you know, as a youth peer, you meet with the family you meet with the youth for, say, a half an hour in the home, and then you decide, oh, an additional half an hour is needed for whatever reason. Even if you, for whatever reason, we're only planning 30 minutes, we get this question quite often, that's considered the same location. You would only bill the off-site rate once because you're staying in the same location and there's not travel between those two sessions. Should we budget plan using the draft CFTSS rates that were provided for after 12 months? So,
I think we're awaiting new posted CFTSS youth peer rates. The ones that are listed on the website now are specific to HCBS, but if memory serves, they shouldn't change significantly. And I think that they do actually state the final ongoing rate without the bump up increase. So they should be fairly accurate, but we are working on getting new rates uploaded to the website.
Okay, all right, we got two more just in. Can you review how a mental health provider becomes a youth peer support provider? So I assume that means a provider agency or the individual provider. If it's the provider agency, like Meredith said, you would apply through the designation portal to become a youth peer support training provider agency. If you want to become a youth peer, which means that either you are newly applying through the portal, or if you're already in the portal and you're adding the service and you'd like to get approved for it, you would just email the OMH provider designation mailbox, ask them to open your application. They will unlock it, and then you would go in and add the service and answer the questions, and then you hit the submit button again, and the state would then reconsider your application with the addition of the service, and then issue you a response in regards to your designation. Right. And if you're speaking about how to be a certified peer, I would welcome you to review that information. It's in detail in the manual.
And information about the youth peer training is also available on the Families Together of New York State website if you're looking to learn more about Level 1 and Level 2 training components and lengths of time and requirements.
Yes. Okay. Does there need to be a place on the recommendation form indicating the parent's consent for the service if the youth is under 18? No, there doesn't. So the recommendation form, like Meredith said, is quite similar to a script, a prescription that a doctor would write, so no, you don't need a parent's consent to that. However, many agencies have adopted their own policies and procedures regarding accepting a referral. So if they were to receive a recommendation, or if you were to send a recommendation to a CFTSS provider agency, typically these agencies will have their own policies and procedures regarding consent before they reach out to the parent with the information that you've provided.
Right, and keep in mind, mental health services are voluntary, and if you go back to the medical necessity admission criteria, you likely will not be admitted because the youth must be available and receptive to receiving the service, and the youth must be involved in the admission process and help determine service goals. So there is an expectation that the youth is actively engaged and will participate in the service in order to enroll in it and be admitted.
Okay, we have another question. Could you please clarify, once the youth chooses to move to an adult services, they cannot return to the children's HCBS or CFTSS, even if they are still within the children's age limit? So we just answered that, but to clarify, so if the youth, so they'd be a youth at that point, so if the youth or adolescent is still under the age of 21 and they meet medical necessity criteria for the respective service, as outlined in today's presentation, they would still have the right to access that service. Right.
Now, keep in mind, there might be circumstances in which actually a young person is in receipt of what's considered to be an adult service and a kid's service concurrently, as long as they're not duplicative, but they might be serving different needs, and it's really about what's best suited for the young person and what they're looking to get out of the service, or where they are even developmentally, or where they are with their needs, which service might be appropriate. So it's really individualized to the young person and unique to their needs and their skills.
And we do actually have, I think, that reference the billing manual, the CFTSS billing manual. There is a grid, I don't know the exact page, but there is a grid that speaks to exactly those duplications that Meredith has referenced.
Allowable service combinations grid, yes, thank you.
So really, I welcome you to review these manuals, the billing manual, the documentation manual, and the program manual that have been referenced in today's presentation.
I think that's all the questions I see right now. Just want to give another minute or so just to make sure sometimes there's a little bit of a delay that folks don't have any additional questions. But again, just a reminder that there are a number of resources that when these slides get posted, you will have access to. A lot of the manuals and listservs and things mentioned during the webinar, you'll be able to find information there to link to those items. So again, if you're in need of some additional information, you'll be able to find it there. I'm just going to give another minute or so for questions, and if not, then we will close out the webinar. I do think we have one more question that may come in, and just give us a second to make sure our presenters get the question. So we'll be right back.
Hi, folks. One last question. Clearly, this person saved the easiest question for the last. What is the expectation on designated providers and managed care companies to identify the youth peer support workforce, as there are only 64 certified providers statewide as of today? So again, I think acknowledging what we had said earlier, which was this is a new field, a new profession, and a newly developed credentialed and certification resource. So as such, it will take time, we acknowledge, to develop a workforce under these new resources, and to identify folks who promote the new role, to get people engaged in seeing value and importance and seeing this as something that they might want to do with their lives. It's kind of like creating a new field of work. It's quite exciting, but it takes a lot to gear up. And so our goal is to really work with our resources to promote this new workforce and field of work, and to really start being creative about how to get people engaged and interested in becoming a youth peer themselves. And I think that we're going to have to be creative and really think about where the workforce might lie, and where we want to really focus our promotional efforts. And so it's not going to happen tomorrow, and it's likely going to take some time. And so I think our goal is to really, as you noted, engage with designated providers, engage with managed care companies, engage with local governments and state agencies, and potentially universities and other areas of that would really be where the workforce lives, and to promote this and to provide this as an opportunity for folks to really get into this new, exciting, field of work. So I think that I would say that the expectation is on everyone, and we're really looking forward to figuring out ways in which to generate interest in developing this new field of work in New York State. Last question is, do we need a signature of consent from the parent to bill Medicaid?
So the signature for consent isn't so much regarding billing as it's regarding good practice. So before you would start service provision, you would need consent in which to do so.
Correct. And I think that there is a language in the documentation manual, and I also think there's language in the program manual which does recognize that since these services go to the age of 21, there will be circumstances in which a young person is already considered an adult and can be their own signatory without the need of a signature from their parent. And so there obviously is an allowance for that within the age range of the young people that we're serving.
And really every agency providing these services, I won't say should, must have policies and procedures related to HIPAA and the sharing and consent to information. So as Meredith said, we would strongly encourage, if you don't already, to visit the Standards of Care, which is in the appendix of the CFTS manual that will speak in a little bit greater detail to our standards and expectations regarding consent as it relates to HIPAA and the release of information, because there are circumstances per the mental hygiene law that does permit a youth to be their own signatory, like Meredith.
Absolutely. And of course, as you know, you specifically use the term parent, but I think we use the term family and caregiver quite broadly in our definitions. So I just want to caution that we are acknowledging that there are legal guardians, that there are caregivers, that there are people who are qualified and legally able to sign on behalf of children as well. And so that also is considered, I think, in our guidance and our documentation as well. Last question, again, is for the language in which we state at least 4 years of experience is needed, one of which having to have been with a credential to be a youth supervisor. The question was, how is that calculated? Again, I think the language is that they need to have provided 4 years of youth peer support services, one of which having to have been provided with the credential. So that's how it's calculated. It's calculated on them having direct youth peer support service provision. It's not other types of work isn't applicable. So it's intended to be as a youth peer advocate.
And to Meredith's point earlier, part of that could be under the provisional credential, so the 18
Correct.
months allowable. So that can factor into that total of 4 years too.
All right, thank you guys. And I believe that is the last question, so I'd just like to thank everyone for joining us. Again, the slides will be posted to our website shortly after today's webinar, so look out for them there to reference material noted in today's webinar. Thank you guys, and have a good rest of your day.